morning, everyone. My name is Parker Chambers. I'm a junior at Spelman College, majoring in economics and minoring in public health from Pasadena, California. My research mentor is Dr. Rebecca Chaudhary, and today I'll be presenting on the impact of Medicaid expansion on healthcare utilization and self-reported health in young adults with evidence from the behavioral risk factor surveillance system. So this is the overview of what I'll be talking about today. And before we jump in, I want to explain the reasoning as to why I chose this project. So this year, I've been involved in a policy project on Medicaid expansion in Georgia, which sparked my interest in exploring its impact nationwide, particularly on young adults. And as an aspiring healthcare leader, understanding Medicaid expansion's role specifically among young adults was something I wanted to explore further, which is the reason why I chose to pursue this research. And so prior to the Affordable Care Act, the fragmented insurance system left many vulnerable people uninsured. So this graph with data from 2013 shows how high rates of uninsurance, the fragmented insurance system, healthcare disparities, and rising healthcare costs impact unmet needs, healthcare needs among children and non-elderly adults. And there are numbers of people that have insurance through Medicaid, which Medicaid is for lower income people who have to meet a certain income bracket, and a lot of people don't meet that, which eventually led to the ACA, and then people also had employer-sponsored insurance. However, there was a significant amount of people that were uninsured. Over 50% of children didn't have access to checkups or general health care compared to those who had insurance, such as Medicaid or employer-sponsored insurance, and non-elderly adults didn't have access to health care. And as we discussed in the previous slide, though Medicaid did provide access to some, there are still many who did not have access, which is how we got to the expansion of Medicaid. And we're looking now to see how this improved healthcare access. So who here knows someone who had Medicaid or who has Medicaid themselves? Okay, I'm seeing some hands. So this is a really relevant topic, and I hope you'll further understand why. And this graph is explaining this well. So essentially in years 2017, 2018, and 2019, adults 18 to 44 consistently report worse healthcare access compared to children 0 to 17 and older adults 45 to 64 and 65 plus, who mostly report better or same access. And when comparing insurance types, those with public insurance or no insurance report significantly worse access compared to those with private insurance. And uninsured individuals have the highest proportion reporting worse access, highlighting these persistent coverage gaps. And overall, these disparities suggest that while the ACA improved overall coverage, young adults and uninsured populations still face barriers to care. And given that, I do want to explain more about what Medicaid expansion is and how Medicaid became more accessible after the Affordable Care Act. So before the expansion, only specific groups such as children, young adults, pregnant women, individuals with disabilities, and certain income limits by state and group were eligible. And so the ACA was signed in 2010, and it was a major healthcare reform that expanded insurance coverage to lower income populations under 65 with incomes up to 138% of the federal poverty level, which just made more people eligible. And so this map is displaying that the blue states, 41 states, including DC, so far have expanded Medicaid, and the 10 states in green have opted out. And that's why there are still these disparities in healthcare access. And in terms of access, there was a big drop in uninsured rates for both the 18 to 25 and 26 to 34 young adult age groups after the ACA, who were staying on parents' plans until 26, which played a key role for the younger group. And Medicaid expansion and marketplaces helped older young adults, 26 to 34, gain coverage. And ultimately, young adults face job instability and limited employer insurance, so these ACA provisions filled a major gap. So this is just raising the question, what has been the impact of Medicaid expansion post the Affordable Care Act on healthcare utilization and health status in young adults? So coming into past work, number one, let's talk about the economic burden of healthcare access. Low-income individuals will face more negative health outcomes and have worse health experiences. Number two, individuals who have access to health insurance generally have a better economic standing than those without insurance. Number three, having access to public health insurance improves both health outcomes and the management of disease. Number four, specifically Medicaid expansion reduced uninsured levels among vulnerable populations, including low-income individuals. Number 5, the reductions in patient debt and increased provider compensation are only 2 of the mechanisms by which Medicaid expansion improved healthcare outcomes and utilization. And I want to highlight number 6, which is saying that Medicaid expansion reduces out-of-pocket spending and has additional positive benefits that I was describing in the previous 5 findings. And most importantly, the impact that Medicaid expansion has on particularly underutilized states and areas. And so these 6 themes are showing us that there's thought to be an impact of Medicaid expansion on health outcomes, but we haven't examined, and this is where I will examine, from a specific economic perspective and the population-wide impact on general health and healthcare utilization among a large population base. So there are a couple of frameworks that can be used to explain the underlying economic theory behind my research question. The first being Grossman's health capital model, where we're looking at the production possibility frontier curve, which essentially is just explaining how people balance their time and money between staying healthy and doing other things. And then the marginal efficiency of capital curve, which is explaining how over time the return on health investments decreases, meaning additional healthcare spending yields smaller health benefits. So together, these models are conveying that early and consistent access to care prevents future negative healthcare outcomes, thus preventing the associated healthcare costs and utilization that these outcomes would have. So this is an equation from Grossman's model on investment in health, where health is a function of the depreciation of health, the time spent improving health, and M is denoting market inputs for health. And this is just explaining how insurance enters into the health production function. So making this more relevant to Medicaid expansion, early investment in healthcare, particularly in preventative care, reduces the need for second and tertiary care that would be necessary if a negative health outcome would persist. So coming into my second theoretical framework, there's evidence that people are price sensitive for healthcare. And the most famous example is the Oregon Medicaid experiment, which is basically saying that when people are provided with free healthcare, as is the case with Medicaid, they're likely to utilize healthcare more. And this table is explaining that. So from the theory, this is the hypothesis that we derived. Medicaid expansion is expected to improve healthcare status by increasing utilization of preventative and necessary care through expanded coverage, lower healthcare prices, and increased investments in health. So from our data, we used pooled cross-sectional data from the Behavioral Risk Factor Surveillance System, BRFSS, which is an ongoing annual survey from the CDC, and our analysis spanned from 2010 to 2023, and we limited our samples to young adults. And we merged this data with data on Medicaid expansion from the Kaiser Family Foundation using state identifiers available in the BRFSS, and we merged everything on Stata, and that's how we collected our data. And we have created the measures number of days, any days of self-reported bad physical, mental, and poor health from these questions in the BRFSS, and then we also created controls on the respondents' individual and socioeconomic characteristics that are listed here. So these are the dates of implementation. I know it looks like a lot. This is all the states. And essentially studies that never passed the law in control states are studies, and studies that did pass the law are treatment states. And so the states in red haven't adopted, the states in purple have adopted in 2014, and then we also have states that adopted in different points in time, which are in orange. So this is our empirical model, which is basically saying that health outcomes are any of the measures of self-reported health and healthcare utilization. Medicaid expansion is an indicator of whether they had it or not. Z denotes individual characteristics, X denotes socioeconomic characteristics, and then our state and fixed effects to the model, which are indicators that capture the impact of being in a particular state and in a year respectively. And then we have our error term, and that can have an impact on health outcomes that we can't control for. And we're identifying the causal effects of Medicaid expansion on health outcomes by utilizing the difference in timing of adoption of the policy by these states. So my results. So I'll explain table 1. And in column 1, Medicaid expansion is associated with a very small decrease in bad physical health days, matching our hypothesis, but the effect is very minimal. In column 2, the coefficient for bad mental health days is slightly positive, meaning we see a very small increase, which is unexpected based on our original hypothesis. In column 3, for poor health days overall, Medicaid expansion is linked to a small decrease, consistent with the direction we expected, but none of the coefficients are statistically significant. And we see similar things for the next regressions. And so our key takeaways are that in the context of the broader economic framework, findings suggest that Medicaid expansion post-ACA is associated with small declines in self-reported bad physical, poor health, and missed doctor visits among young adults. And so these are consistent with our conceptual frameworks. And although the estimated effects are small and statistically insignificant, these findings are important because they highlight that insurance expansions alone may not be enough to generate immediate large health gains, especially in relatively healthy younger populations. So, yes, and these are my references. Thank you.